So in the second session, we gave you some examples of ways of including QI in your courses. And then today we want to go over how this plays out after graduation, post-graduation, and in practice. So Liz Carlton, who is the Director of Quality, Safety, and Regulatory Compliance, is going to talk first. Then Dr. Tim Williams, who is the Medical Director of that department, is going to talk. I will be talking for Dr. Laverne Manos. She was going to do the informatics piece. So don't ask a lot of questions about informatics. Heads up. Yeah, just store them up. So I will let Liz go ahead and get started.
Good, thanks. Light group today. I think it's the snowstorm. Kept everybody at home. I like small groups, though, because then we can ask questions and talk back and forth and dialogue a little bit more. So these are the same objectives that have rollen over from each of the presentations, so we won't go into details. But we were asked to talk about how do you do it in real life. And I thought we would start by talking about why do we do it? Why do we do performance improvement? And I think there's a lot of different reasons. One is so I don't look like I do today, which is courtesy of the weather and walking in from the parking lot, or we look like Einstein. But, you know, he has that famous quote, the definition of insanity is doing the same thing over and over, expecting a different result. And that's kind of what, if you only do quality assurance and you only check the box and you have the same result all the time, you never make any difference, that's what you end up with. And so that's one of the reasons why you absolutely want to do performance improvement. We also do it because we know it's the right thing to do for our patient, right? That's the business that we're in ultimately, is providing the very best care for our patients. So we want to create and produce that quality product. You know, healthcare hasn't had that business mindset. It's only been recently that they've kind of shifted the paradigm to kind of have this business model where you focus on satisfaction as one of your indicators, because before you just did, sorry, Dr. Williamson, what the doctor told you to do, and there was no, well, we'll talk later. What's wrong with that? You know, so you just did what you were told, and you really didn't have any option. Maybe you didn't have any choices about where you could go. But you know, society's become very sophisticated now. They're very smart, and people can get, as my grandma would say, get on the Google. So she gets on the Google and looks up her new doctor to see if he has, you know, 1 star, 2 stars, 3 stars, or if somebody has posted something bad about him. And she's smart enough to know that. And so you don't want your consumers, your patients, to be living in that world. You want to have that quality product. And then, of course, as you do performance improvement and you involve your people, you know, your staff that are working and functioning in it, that empowers them to do a better job. It helps them impact change, and so they have ownership, and then their satisfaction increases as well. That didn't translate very well for you guys, did it? It's kind of pale up there, but we also have things that we're told that we have to do. We call this the voluntold. So if we want to participate, we have to volunteer to submit this data. And so these kind of voluntold things come from our regulatory and accreditation agencies. So the Joint Commission, which, you know, is a voluntary participation, although CMS will not pay you for Medicare and Medicaid unless you participate in either TJC or one of the other, I think it's, oh, it just left me, it begins with a D, regardless. But you have to participate. So they have a whole list of things that you have to do, and you have to participate. CMS has a whole list of things, and that is getting deeper and wider in their work with the never events and the pay for performance and the requirement to document the present on arrival or present on admission so that you don't get dinged with the hospital-acquired condition. And then all around transplant, CMS has a stack of regulations that's about this high that they send surveyors in that you have to participate. And then you have your special program recognition. So if for us in the hospital, we're, you know, level 1 trauma center, level 1 burn center, we're a dedicated comprehensive stroke center, a chest pain center, all of these kind of subspecialty areas, and they have regulatory compliance that's associated with them. And so you have to do certain things, performance improvement, and show certain outcomes measures in order to get those titles. And then this whole concept of public reporting, like I said, with Grandma getting on the Google to check out what that hospital's rating was for infection or what that hospital's rating was for patient satisfaction, the HCAHPS scores. People are very intuitive about that. you know, you talk about all the rest of the groups that jump in there, not just CMS and those focus that we talked about, which is just a little more detail listed there, but that leapfrog group that came out several years ago. And they did that initial survey where they found that out of over 1,200 hospitals, 87% of them didn't follow the recommendations, evidence-based standard recommendations. And so from a lot of that work came the Institute for Health Improvement's initial aims. You guys remember the 100,000 Lives campaign, and so this was the initial work that came out of that group. And so they said, here are the best practices that you need to participate, and you have to participate if you want to be a good performer. And so they kind of set the stage for what the expectations would be just around general performance improvement. A lot of places are still struggling with just trying to get these things into place. And you know, for us, I would say we have work going on in every one of these. Some we've mastered, and some we still have opportunities. After the 100,000 lives, then came the 5 million lives, because 100,000 wasn't enough. We have, I don't know what's next. A billion lives campaign. And so this platform then shifted the focus a little bit, not just to decrease those hospital-acquired conditions, but to decrease harm overall. And so they started focusing, spreading their impact just a little bit wider than that. So looking at prevention ulcers and MRSA, the medication administration, surgical complications, and then the bottom bullet, which I think is the most interesting one out of all of these, was getting the board on board. So making sure that hospital board members, people who are in decision-making capacity, people who are leading the charge for that organization or that facility's change process, resource allocation, budget, all of those things, that they know exactly what the issues are in that particular facility, so that they know they can create that progressive performance or leverage their processes to get better performance from that group. So there's a lot of work that goes on in that. Yep.
I think it's worth saying real quick that our hospital's board is very engaged. They get quality data and board meetings, professional quality. Our board, we're fortunate they get it. They're engaged. They want to see that just as much as they want to see everybody else.
That's exactly right. And a lot of hospitals don't even have, or a lot of organizations and facilities don't even have a separate quality board. You know, it's just kind of rolled into all the rest of the stuff. And typically, if you look at agendas, I went to an IHI presentation on getting the board on board, and they put up like 4 or 5 different agendas from some big names across the country. And what do you think the first bullet was? Finance. Always the first bullet was finance. And so shifting that paradigm and putting that quality in the first bullet is the most important thing. Why else do we do it? We do it because we suffer from the bitty waddy. If y'all were here the first presentation where I talked a little bit about the bitty waddy, because that's the way we've always done it. You guys know the bitty waddy. Do you have that in your teams, in your groups, and what we do? We suffer from that all the time. And it's easy to say, well, that's the way we've always done it. And so what we ask people to do is to think about, if that's your answer, if someone asks you why do you do it that way, and your answer is the bitty waddy, then we challenge you that maybe that's not the right way to do it. Maybe there's a different way to do it. Maybe there's some opportunity to do it right. What about the pet rocks? How many of you are as old as I am? Did you have a pet rock? Am I the only one who had a pet rock? I don't believe it. I don't think there's self-disclosure here. So I did have a pet rock, and we thought the pet rocks were fabulous. But what was the point of the pet rock? What did it do? Do you remember? It did nothing. It did absolutely nothing. It sat there, and it was so good and comfortable and fun to take care of, and it was so easy to manage because it just sat there and it did nothing. And there's actually a manual that came out that said how to take care of your pet rock, and you know what was inside of it? Nothing. There's nothing inside of it. And those pet rocks are those things that you do that you're not really sure what the purpose is. You know, you're not really sure why you have it. Well, maybe it's a bitty waddy, maybe, I don't know, because it's always been there. Do you have any of those in what you do? Can you think of any pet rocks? Maybe? What about the sacred cows? Do you have sacred cows that you work with? These could be people or processes. Usually we refer to them kind of the people, but these are either the people or the processes that are too highly regarded to be open to criticism. So it's immune from tampering. Sometimes this is justified by past practices, so it's in that bitty waddy mode. Sometimes it's just because people are so resistant to change that they're kind of blind to what's going on around them, or they're afraid of change, which is pretty typical in the change process. I love this cartoon. It says, "Sacred cow, I'd like you to meet the sacrificial lamb." You know, in the nursing world, where we see this happen a lot is with that very tenured nurse and then that new grad that comes in, and that new grad who has just gone out of school and knows the best practices, and always wash your hands, and always talk to the patient, and always, and they come on board, and that tenured staff says, yeah, we don't really do it that way. This is the way I do it. This is the way you need to do it. And then they usually kind of take the hit on that. So we just need to be cognizant of that. But got my hair on the thing. So anytime you have this concept of the sacred cow in place, be it a person or a process, you need to think that that's probably not right, and you can do things a little bit different. How about the golden goose? You know, the golden goose is that thing that comes in, lays that golden egg, and it's supposed to be the best, greatest, most wonderful thing. It's going to change the world. It's going to change how you do your practice. It's going to change how you practice medicine. It's going to change how you teach your class. It's the best thing since sliced bread. So I remember a couple of things that I thought were, or we thought, this kind of dates me when we see some of this stuff out here, but we used to put a mixture of sugar and Maalox, make a paste, and we put it on decubitus pressure ulcers on our patients in the nursing home. Does anybody remember that? Am I the only one who did? You did. Okay, good. Validation. You know, so that was supposed to be the greatest thing. Did that help our patients? No, it actually made it worse, right? What about alcohol rubs for febrile patients? What happened when we gave them alcohol sponge baths? What do you remember? So they would start to shiver, right? And that would make it even worse, and their temperature would actually get higher instead of lower. What about telling the patients with gastric ulcers to drink lots and lots of milk? Remember that? And then what about hyperventilation and brain injury? So we actually had science that supported this one, said that if you hyperventilate a patient, you actually decrease the blood flow to the brain. When you decrease the blood flow to the brain, you gave the brain more room for the bleed or the swelling or whatever was happening, and that was a great thing. And so every trauma patient that rolled through the door that had traumatic brain injury, we hyperventilated the you-know-what out of them. Think about that, decreasing blood flow to the brain. Does that make sense? It was good in theory, and it did work, but it didn't do what we said it was going to do. It was actually more damaging. And so that's kind of what that golden goose is, and usually with golden goose, you just get a lot of golden goose poop associated with it. So you have to be very careful of these things that come out and you think are just going to be magical and going to be everything that you want and need them to be, and really need to vet it out and make sure that they're really evidence-based and they really have the impact and the effect that you want. So we've talked about all of this. We do it because it's the right thing to do for the patient, because we've got this public eye out there that's really looking at us, because we know it's linked to reimbursement and compensation. And, data, we're a data-driven society now, and I know we're going to talk a little bit more about that. So you have to find that opportunity, and sometimes it's presented to you in those ways that we've talked about, voluntold or the sacred cow. And when you find that opportunity, you need to make sure that you identify what it is exactly that you want to accomplish. What is the reason or the outcome measure that you're going to use for that? And sometimes it's because your organization has a goal, or you've established a stretch goal. Sometimes you have a patient safety issue. You have those regulatory bodies we talked about, maybe satisfaction, or it could be a specific situation. Would you ever take an isolated incident and create a performance improvement program around that to change the process of the system? That's a yes. The answer would be yes, right? Because it doesn't, what you don't want to have happen, you don't want to be reactive and put process improvement for every single situation. But sometimes that situation is so grievous and egregious, and you know that it is a system issue. It's not an isolated provider issue. It's a system issue. And you have to put something in place so that the next time that potentially can happen, you can do the work that needs to be done. So do you know this guy? Do you recognize this picture? Ignace Semmelweis. Am I saying that right? Semmelweis. The W is the V. Yeah, so he's Hungarian? Something along those lines? Is that right? Yeah. Yeah, so he had this very interesting thing. So he had a cadaver lab going on, and where he taught medical students, physicians in training, and then he would then go and deliver babies. And he noticed that after he had several childbed fever deaths, that there seemed to be a direct link to the group that participated in the cadaver lab who then went and delivered babies when there was no hand washing in between. I know, gross, right? And so he actually wrote a paper way back when, and this was the opening line: always wash your hands after dissecting cadavers and before delivering babies. That's pretty good advice. But he had this opportunity that presented to him in his practice, that he was able to put performance improvement around and put some changes into place for that, 1847. So we have a lot of opportunities within the hospital, and I'm going to share, Dr. Williamson and I will give you 2 examples of some very specific patient-oriented examples, but we also do a lot of work based on, our core measures, if we have a new or revised guideline, so if new evidence comes out that changes the way we want to do our practice, or a new initiative or problem area, or, like I said, if you've just ever asked why do we do it that way. So, can you guys see this? Can you dim the light? Is there a light switch over there? Can I do it up here? I don't know how to do it. Can you guys see this picture very well? Going the wrong way. All right, can you tell what that is? What's wrong with this picture? So it's a car crash, okay? It's a car crash. What's wrong with the picture? No stabilization of spine, no long spine board, no spinal cord, no C-spine collar. What else? What else is wrong with this picture? No gloves. Yeah, exactly. No self-protective, personal protective device. What's the milkman doing over here? Why is he getting busy in there? Anything else wrong with that? Lifting him up by his belt. There's a lot of things. So my background is trauma. We can turn the lights back on now, please. So my background is trauma, so I love this slide because this is how we used to do it. This is the way we did it. We didn't know any better. We didn't think there was another way to do it. We didn't think that it caused additional damage. This is just the way things were done. So this is the way we do it now, right? You package a patient correctly on a long spine board and a cervical collar, and they're completely immobile. You cannot do any more damage to that spinal cord because you packaged them the right way. So a while back, they created, so it's hard to see here, but these are called extrication collars. They are plastic. They lay flat. So from an ambulance perspective, they're really easy to store. You can have multiple sizes, and then you can adjust the size down, so you don't have to carry too many of them. So from a practical workflow issue, they were great. But they are literally hard, white plastic. Any thoughts about that? So when we would put these on the patient, they would then lay around for days and days and days in a hard white plastic collar waiting for that to be cleared, right? For their x-rays to be done, for somebody to read the x-rays, to decide if there was an injury. And so our patients became very, very at risk. So we kind of knew this globally. Folks had put a couple of things into place. We had tried some systems approaches. We really couldn't make anything happen. And then we had a single event that really escalated the problem. We had a 68-year-old male who came in from a motor vehicle crash, came in with this extrication collar on, and he laid flat, completely flat, in the bed, not moving, extrication collar on for 5 days. He got an occipital decube that was massive and required plastic surgery for repair. He got aspiration pneumonia. He also got very angry, as you can imagine. And by the way, did I mention he couldn't eat during that time? We didn't feed him either. And so he was 5 days late on getting nutrition as well, which, do you think that helped his? Exactly. So it was just a hot mess all the way around. That'd be the best way to describe it. So we knew that we had some goals, not just for this particular patient, but from our system overall. Can you guys see that x-ray? Do you see what's wrong with that spine? So you don't have to, you don't have to be a neurosurgeon to know that that's not right, right? Those are supposed to be lined up, not offset like that. So we know that we had some goals, right? So we wanted to have optimal outcomes for our patients, which meant that we wanted to do spinal immobilization appropriately so we didn't cause additional spinal cord damage, because that can be devastating. It could be life-ending for patients. We knew also that we could not, we had to do a lot of work to prevent secondary injury, and that secondary injury, it was pneumonia, aspiration, lack of nutrition, decube, and just patient satisfaction. We had tons of opportunity there. And we needed to do a lot of work on that. And we also had to make sure that we did it in a very cost-effective method. We knew that by by decreasing the amount of time that it took to get that C-spine cleared, not only would it decrease the complications, but it also would decrease length of stay. This guy couldn't even start doing what he needed to be doing for 5 days because we hadn't done that work. So we put some measures in place, and we looked at the background. We got our benchmarks. We were able to get it out of the trauma literature and the best practices. There wasn't a science that said you absolutely have to do it this way, but what they said was the facilities that have the best practices, that have the best outcomes, have targeted this 24-hour mark. And so within 24 hours, you either want that C-spine cleared or you want to have a definitive diagnosis. The best practices also changed that extrication collar, that hard white plastic collar, in the trauma bay. So before they ever left the emergency department, they would get a collar that had some tissue offloading properties on that. So in that white collar, capillary breakdown began in 20 minutes, within 20 minutes. And so if you could get that off and get a collar that had those tissue pressure offloading properties to it, much more comfortable for the patient, much less risk for decube. And then you had 24 hours to either clear or definitive diagnosis. So what's wrong with that plan? That's a beautiful plan, right? Do you know how much the Philadelphia collars cost? They're about $17 a piece. Okay, it's not terribly expensive, but that's $17 per patient that we hadn't been paying before. $17 per patient that in less than 24 hours would most likely be thrown in the trash. So we see about 15 to 2,000 trauma patients a year. You do that math, it doesn't add up to what that 5-day extended length of stay, decubitus ulcer or occipital ulcer requiring surgery, aspiration pneumonia requiring antibiotics, that math doesn't even add up. But we had to make that case to the finance people. We had to show them how that initial investment up front would have long-term downstream effects. And that's one of the things in performance improvement that you have to put in place. You have to have a plan for that financial component, because the people who have the dollar control will push back right out of the gate and say, that costs money. We can't do that. We don't have budget for that. And so making sure you have the financial piece of it is important. The other thing that was important is that we couldn't do this based on one case, right? Because they would say, well, that was one incident. You haven't had any other problems. So we, again, had to make our case. So we looked at our registry data, and this is where you can't say that. I mean, you have to say that having the information, data is power. It is absolute power. So we went back and we looked, and we saw that in just doing a 1-month review, 94 patients, we had none that had the extrication collar removed. 0 compliance on that. And only 72% actually got the C-spine cleared within 24 hours. So we could absolutely make the case. This wasn't an isolated incident. This was a huge system problem. So our plan was to, like we said, look at the literature, gather the best practice management guidelines, develop our own evidence-based protocol, educate, communicate, and set expectations so that it became hardwired into the process. It wasn't optional for a patient to leave the trauma bay with an extrication collar on. And so we really had to message that this was not an opt-in or opt-out. This was the expectation. So we did all that, updated the protocol, we educated everyone, even beyond the emergency department to the unit and the floor, so that if the unit or floor got a patient who had the white collar on, they didn't have to know all the details of it, but they could call us right away and say, hey, I got a patient with that hard plastic collar on. I know y'all aren't supposed to, that's not supposed to happen. So just putting that safety net into place. We continue to do that audit on that, and this was, like 7 years ago when we initially did the study. And put this process into place. We continue to do that audit just to be sure. So when you look at that ongoing data, you can see that when we first started, we were really no good at it. But we very quickly shifted what we needed to do because we did it right. We put the system in place. We had the equipment in place. We made the case for it. We had people whose role it was to do that work. That was their job. Debbie was in the trauma bay, and she was the resus nurse that day. It was her job to get the collar and bring it to the physician to be made. So we had these kind of safety nets in place. You can see in certain areas, usually around July, the compliance would start to dip. What's that all about? New residents, exactly. So we put additional work then into the new resident orientation to make sure. So the point of this is it's not a one and done kind of process. You always see that there's always ongoing opportunity and more work that can be done and more opportunity to keep looking at it. We don't look at it monthly now, and you can see as the years have gone by, we've shifted it to quarterly and then to twice a year, and now we just do run spot checks twice a year to be sure. I will tell you that since we started this work many years ago, 8 years ago almost, we have not had one occipital decube in our patients, which is an amazing thing. And so that's a really big deal. So we continue to measure those studies, and I feel like in this particular case we have been able to implement the ACT, and that A in the Plan, Do, Study Act, if you remember that, is the hardest thing to do, to hardwire that into your process and your systems, and you really have to do that to, so that it just becomes that second nature and it's not optional for that. Okay, I think that's you.
I apologize. I've got a cold, so all hopped up on cold medicine. If anything I say doesn't make sense, you'll know why. More so than normal, I would say. So I think Liz just presented an excellent example of how we took a hospital-acquired condition, dove into it, and so this is a little different. We're going to show you another hospital-acquired inpatient condition that we took on, and then I think you'll see some examples of outpatient. But as Liz said, the part of the problem is not only are we reporting these sorts of things now, but that, in fact, as of 2008, more and more of these things are not being paid as complications and so-called never events. One of these is VTE, so DVT and PE. So there are a lot of things that we have to measure around VTE. This is part of the problem that doesn't get talked about a whole lot, but we have ARC measures for VTE, SCIP measures for VTE, core measures for VTE, probably others that I'm forgetting. They all have different reporting requirements. They all look at different populations, and so that becomes challenging as well. But we have these things that we have to meet, meaningful use requirements we have to meet for VTE, and so again, has to be hardwired into our system. So we had an opportunity. This is aligned. This is great if this is your retirement portfolio. This is not good if it's a hospital-acquired condition. The blue bars are the actual or the actual incidence of VTE events, and then the red line are the rates. Of course, I always advocate for using rates whenever we can. And then we really don't have a lot of time to talk about run control charts, but really would make a plea whenever that you have the opportunity to use run control charts to present data. It's so much easier visually to see. You can just look at the run control chart here versus like the blue graphs. What you're trying to do when you're looking at that is visually make a run control chart in your brain. And so whenever you have that opportunity to use run control charts to do that, this is the trend line, and again, not what you want to see for a hospital-acquired condition. So first step, of course, is to gather the team. We put a team. This is not to say that most quality improvement projects need to be this large. This is one of our larger, if not one of the largest quality improvement teams that we've put together. But we really, I think the keys are to make it interdisciplinary. So we have nurses, physicians, pharmacists, education people, quality people, all sorts of different physical therapy, all sorts of different disciplines. And then also an up-down approach, meaning that we have frontline people, because you got to know what's going on in the front line. And so we have frontline nurses, residents, et cetera. And then we were reporting on a regular basis to upper line executives. So we would meet with Bob or Tammy periodically to share what we were doing. So you got to have a very up-down approach and multidisciplinary. So you got to decide what your goals are. Our goals were pretty simple. They were to decrease VTE rates, PE rates house-wide. Some of these other things were secondary, but I mean, the ways that we were going to get there: create standard order sets, increase staff awareness, ensure evidence-based management for prophylaxis, identify trends, and of course meet meaningful use and core measurement requirements. But the bottom line is we wanted to decrease VTE rates house-wide. And initially this started off, okay, just looking at SCIP, but I think you really run the risk of missing the boat if you just start looking at one population. We decided we're going to look at the whole house, and we're going to try to drive the entire house's VTE rates down
And then by doing that, we would hit all the individual components as well, theoretically. So the first thing really is that diagnostic journey to see where your problems are. And of course, we went into it. I may have said this the first visit. We went into it. We knew where the problems were. Darn orthopedic docs, if they would prophylax their patients better, we wouldn't have any problems, right? Had to be the orthopods. So we reviewed, 250 charts or so, ballpark, and we did a very thorough review of looking at the different issues going on. And of course, what we found was not so much the orthopods. In fact, they really weren't on the radar screen. This is a Pareto chart. We talked about it in the first session. I would say it's probably the second most useful tool in quality improvement. And it really helps you prioritize what are the big ticket items. We only have so much time and money, and so if you're going to spend all of your energy on delay or making people wear their SCDs, you're going to miss the boat and you're going to not get the bang for your buck. So when we did our Pareto chart, what we identified, yes, there were some patients who didn't have prophylaxis. We were going to work on that. Yes, there were some coding issues. There were patients, and this is a big deal when we talk about public reporting, going back, and we spent a lot of time making sure that these things are accurately coded before they're released, because a lot of these that we found were actually like ENT, the flaps, thrombosed, kind of the Rambo flaps that they do. They had flaps thrombosis, and those were being coded as DVTs, and that was falsely elevating our numbers. But our big issue was that, A, we as an institution used way too many PICC lines. B, the PICC lines are heavily associated with developing VTEs, and most of the VTEs that we had were, in fact, PICC-related. A PICC-related DVT counts just as much for public reporting, still has to be treated, et cetera, as a massive PE. So we still had to capture those. And in fact, our usage of PICCs was much higher than any of the other UHC hospitals. So one of the things we did, we wanted to decrease our PICC use. That was where some of our first measures went. We developed this vascular access device algorithm. It's been used by the IV team. I think this is a good caution, is sometimes we can make things too complicated. How many interns do you think are carrying this in their pocket, pulling out the vascular access device? I don't think it's been really utilized. I think as we're going to re-message this, I think the answer is going to be, do you need a PICC? And if so, do you need more than one lumen? So I think that's a simpler message than that, right? Do you really need that PICC, and does it really need to be more than one lumen? So, but anyway, that was developed. And over time, we saw that our PICC usage substantially decreased and is headed in the right direction. This goes down through October or so, well, I guess through December of this past year. But we're starting to see this trend back up where the PICCs are starting to be used more frequently. And it's a good comment. We talked about balance measures last time. Sometimes you can have unintended consequences. And for example, one of the things I know is being discussed is going to continuous Zosyn in the hospital as a potential measure as part of some of the other initiatives that are going on right now. But that would require a central line, which would require probably more patients to get PICCs. So, you know, we're kind of going, whoa, time out. Do you really want to do this? Because we're already starting to see it bump back up in our PICCs. And then we really wanted to increase. Education is always important. We've done at least 2 different multidisciplinary events. We've got a web page. We had a video trying to educate folks. One of the guidelines for VTE prophylaxis, it says that every institution should develop their own guidelines that make sense to them. We didn't reinvent these. These were largely based on the ACCP guidelines, but we came up with some of our own guidelines and a simple scoring tool that basically you can't read it very well, but these are the risk factors and some of the contraindications. And if you have X number of risk factors, it tells you what to do. Any good quality improvement project ends up with a badge buddy. It's a rule. I know we're up to about 3 inches worth of. Anybody got a badge buddy bigger than 3 inches right now? Thick. But so you can flip through, get them out to all the residents, to the nurses, et cetera, and have that information there so that there would be no excuse for being able to not being able to risk assess your patient. We know that education is a very weak intervention, and so wherever you can hardwire things, We did so, and so that we standardized our order sets. We went back through and looked at the electronic order sets. We looked at BPAs, best practice alerts, that fired if you weren't getting your prophylaxis, and some of those things had their limits as well. And we just took on a number of things, knowing that, yes, PIC was our biggest issue, but we still had some of these other things that we had to do as well. And I think a lot of these that I've talked about. We did make a video, which had some outstanding acting in it, I think, and it's out there somewhere in a YouTube graveyard somewhere that you can potentially find. And we took the data. Data is important. We took data to anyone and everyone who would would listen to us. Of course, everyone says, well, our patients are sicker, but we had those conversations. And any good QI project has a candy cart initiative that goes around with candy to the nurses. And again, this was very interprofessional, transoccupational, whatever the cool word is we're going to use today, but using physician, pharmacy, physical therapy, nursing, all owning a piece of this and saying this is really everyone's problem to own. We tried to make some really cool posters, but could never get past. There were all sorts of licensing issues with like putting different teams on posters, so we never got there, but very much team approach. And then, of course, the family. You can't leave out the patients and the families. The one thing I don't think we've done very well, we've not included the patients on the committee. We should do more of that, but we've educated patients and their families about these things as well. So again, this was the before picture, going the wrong way. This is the after picture, and I'll show it to you in a little different way. December of 2010 is when we initiated our team, and then we've seen a fairly steady, measurable decline over the past 2 years or so. This is, again, a little different way. Run control charts, very powerful. It's beyond the time of what we have to discuss today, but control limits, if you're familiar with them, can be another very powerful tool telling you if what you're seeing is just random variation that you would expect to see because that's the noise of the system, or if this is real, and but this appears to be actually real. Again, going the wrong way. We introduced the team, and we're starting to see a decline. But that maintaining that sustainability is incredibly difficult. I think that's the toughest thing. Everyone's excited up front. We're going to go change something, woohoo! But 3 years into it or 2 years into it, trying to sustain those gains, everything we've ever done, you start seeing that slippage, particularly in an institution such as ours, where you've got new residents, new nurses, new students that change on a yearly or every so often basis. So that was just another example of real-world application of these sorts of things. Yeah. Sure. I think there may be a little bit of that touched on in a second, but in general, I will say the Heron is really a good place to start fishing, but with the de-identified data. But a lot of times you need to then go with identified data to really be able to do the level of detail to see what the issues are. Future state, my Tim's World, Tim's Stream, would be a dedicated department with dedicated analysts with dedicated data warehouses that would coordinate, because right now we've got all sorts of different projects, all different types of data requests going to all different types of places. So in Tim's World, that would be better, but Tim's World is not always reality. But Exactly. And those conversations are actually active and ongoing. Have just recently started about how do we protect the data, how do we, the data that comes from the hospital, how do we protect how that's presented, how do we protect, more importantly, the patient's data so we don't have HIPAA breaches. I think all of that, how do we make sure that people get good data? And so we're looking at all that right now.
So now I'm going to talk about something I don't know a whole lot about other than the data itself and trying to pull it from our primitive databases that we use at an ambulatory clinic without electronic records. But I think what Laverne wanted to get across is, and I'll just go ahead and move on to the next one, is that we have to be good stewards of the data. We want it to do what it's supposed to do, or we want it to be worth something when we put it into those databases. We want to be able to pull out good data from that. Its collection is expensive, as well as analysis. It's very expensive. She wrote here that collection and analysis, nurses spend more than a third of their time documenting. It's unnecessary data, or not unnecessary data, but unnecessary data input is one of the most expensive data wastage, but the cost grows. Unneeded data is entered, unneeded data is stored. That unneeded data is queried, manipulated, scrubbed, and then is analyzed. And on a much, much smaller scale than this, than KU Hospital, the clinic, I spent far more hours scrubbing data than I wanted to before we could really take a look at the information. And then, it's still kind of questionable, and I'll go over that just briefly here. It needs to be designed correctly, well-defined of what goes into where. Do you guys have anything to say about that?
Yes, I think that's a really important point. So when we got the electronic health records when we signed with Epic, we wanted our own version of Epic, and so we changed a lot of stuff. We made it very kind of KU-centric. We changed a lot of stuff, and we looked disciplined in our approach. We didn't focus on what that standardization or approximation should look like, and how what the technique we use. And so when we then got the upgrade to Epic, which in the electronic world, those upgrade, you got version 2, 2.1, 2.5, 3, 7, 94, whatever. When that upgrade came, that upgrade didn't fit ours because we had changed it so dramatically to be very specific to us. And so looking at it not just from improving your system, but improving the health system overall is something that has been, so it didn't interface with some of the other groups that we were using. And so we really weren't very logical in the approach, and that was a
Okay. So at Silver City, and I'll give you just a brief background on Silver City so you have an idea of some of the challenges, but we wanted to know if we were doing what we said we were doing. So if our patients were receiving the best possible care and achieving the best possible outcomes within reason, and do we know what strategies are more effective in the population that we serve? And we wanted to make sure that we were meeting standard of care and that our patients' outcomes were better. So briefly, something's missing off of here. Anyway, Silver City is a faculty practice clinic for the School of Nursing and School of Allied Health. It's multidisciplinary. It's a safety net clinic. Oh, okay. We have, this is fiscal year 12, 43% of our patients are uninsured. The Medicaid S-chip is 45%, and most of those are children. And then we have 5% are Medicare, 7% are private. So, high population of uninsured. 78% of our patients are at 100% or less of the federal poverty guidelines. So we have patients with multiple medical issues, chronic diseases, and we also have social and financial constraints. So when we've been doing QI for several years. We did that, it was part of our medical home. We are recognized as a patient-centered medical home. And so we wanted to take it up a notch. We were really focused in the beginning on processes. And then we discovered that we were doing a lot of processes and doing them, we were following the standard of care, but we had no idea how our patients were responding to that. So we were kind of practicing, I felt like, to all the processes and not to the patient. So we had these principles, which are common. I think you probably discussed them in the beginning, in session 1, but we recognize that that QI is system and processes, and one of the systems is the patients. We wanted to focus on the patients. We also, because we're small, we wanted to build a strong, cohesive group and team. And that was probably one of the most difficult things. And then we wanted to focus on the use of the data. We recognized that it was complex, that there's not one person in the organization that knew everything. And the processes involved more than one discipline, more than one work area. We had to be creative for a variety of reasons. We are very thinly staffed, and so we all wear multiple hats. And so we had to fit QI, and I don't mean that to say that it was lesser than anything else, but we had to fit it into our constraints. And the last thing is we had to have buy-in from everyone. And I am going to skip over this because this was talked about a little bit. And I'm going to go to kind of our process, and this just seems like a really watered-down version of the hospital. And it overall is a watered-down version because there were many meetings. It just wasn't this one. But first of all, the group met, and we wanted to know why we were doing what we were doing. Are we meeting the standards? All of those questions. Are the standards evidence-based? Or are the things that we were doing evidence-based? What is required? You all talked about all of the required reporting. Well, we go after many grants to try to keep our doors open. And a lot of those those grants require that kind of information. So we had to have a solid basis for submitting to our grants. We also discussed what outcomes that we wanted to look at, the frequency. We developed the QI plan and how that data was going to be collected. Then we formed teams. Now, in our clinic, that team might be 3 people. I think some of them are 2. Very small. It involves the receptionist, the MAs, providers, our clinic RN, and we have full support of our leadership team. But the teams, we wanted everybody involved in the problem solving. Let me go back. The teams then we have a diabetic team, we have a hypertension team, we have, what else, Chris? Colorectal, mental health, yeah, mammogram, and then there's some business things. So those teams took responsibility for pulling together the outcomes, the measurements, and kind of an overview of how that data was going to be collected. What we found is that with our systems, we have an Excel spreadsheet that tracks our referrals, and that's one of our metrics. And we have a chronic disease management system, which is CDIMS. We had one person then collect the data and analyze the data because it was a little confusing, and we've learned a lot of lessons from that. And I'm going to go ahead and go on through this because we're running out of time. But with the data collection, we posted or shared at a group meeting what the results were, and each team then took the results and came up with a strategy to improve the outcomes. Does that make sense? And we had developed a threshold where we wanted to be. The team put those strategies into action, tried to develop policies and procedures to go with that so that we could ingrain it in the staff, and everybody was doing the same thing. And the cycle repeated itself. We do this on a quarterly basis. This is the diabetic, our quarterly, third quarter of fiscal year 13, and then we do kind of a yearly, a running, or whatever you call that, but we do 12 months. We look back 12 months. I'm on cold medication too, so. Anyway, you can see and we also divided it up into providers. So each provider knows what they're doing, although some of the numbers are really low. I mean, not many patients, so that kind of, gives it a different look. One patient can really throw off a group of 3. So, but we know overall how we're doing. Hemoglobin A1C is less than 7 in 67% of our patients. That's pretty good. Now, this is where we had an issue with data integrity. We had, I'm the data collector and analyzer. And it was, what I found is that as I went through the different databases, it wasn't clearly defined what goes in. For instance, there was inconsistency in our referral spreadsheet about the type of visit, and that made a difference as to the need. One of our metrics is that we want to get results of a referral back within 14 days of the patient's visit to that referral person. But we have priorities also built into that. So if something's a priority 1, that's pretty high up there. This is something that needs to be dealt with. It's not routine. And we didn't have that clearly defined. So the data was, it just was, I don't know, lack of a better word, I couldn't trust it a whole lot. So we sat down and we defined that, and you can, and it made it much more clear, and the data was definitely more reliable for the next quarter. But we learned this as we went along. It wasn't something that just happened. We better close off. Depression screening was the same way. Anyway, this shows we celebrate this kind of stuff because this shows that we are across the nation with community health clinics, that we are above the nation. So we're proud of that. We're going to celebrate it. And now our next move is we don't know really what strategies are effective. And we also will probably, since we have done maintained hemoglobin A1Cs and hypertension and those kinds of things, we've maintained our threshold. We probably will table those and maybe look at them every 6 months and bring in some new metrics. But that'll be bringing the team together and deciding on what that will be. That was a rush. And I don't know that we have time for questions. Any questions or? Man, I feel like I. Well, I think if we would have talked more about the data, if we would have talked more about informatics, I think that would have been definitely been important, and that might be what we need to do for November too. The 4th one, yeah. I cannot think of words.
Here, it's still on.
Huh?
You still have your microphone.
I'd do that at home if I've got my microphone.